Welcome back to the deep dive. Today, we are opening up the map, literally, of the human lungs. We're tackling the latest updates to Lung-RADS, specifically version 2022. And before you think this is just some, administrative housekeeping about updating a spreadsheet, hold on.
Right.
This is actually a really tense story about the balance between catching a deadly disease early and, well, the very real risk of over-medicalizing normal human biology.
That is exactly the tension at the heart of this update. I mean, we often think of medical guidelines as these static, dusty rule books carved in stone.
Right.
But Lung-RADS is a living document. It has to be. It evolves as we learn more about how lung cancer behaves and, frankly, as we learn from our mistakes in previous years.
The stakes here are they're incredibly high. I was looking at the background material you shared, and lung cancer is still the leading cause of cancer death.
It is.
But then you see these numbers from the big trials, the NLST and the Nelson trial, and they're showing mortality reductions of anywhere from 20 to 39% just by using low-dose CT screening. Those are massive numbers.
They are. And those trials prove that screening works. The challenge, though, is doing it right.
Yeah.
You need a standardized system to report what you see.
Sure.
You can't just have a radiologist say, it looks suspicious.
Yeah.
You need a number, 0 through 4, that tells the clinician exactly what to do next. That's what Lung-RADS does. It translates pixels into action.
But what surprised me is that they felt the need to update it so significantly. I mean, a nodule is a nodule, right? Why did we need a version 2022? Was the old map wrong?
Wrong is probably too strong a word. Let's say it had blind spots.
Okay.
As we've screened more people, and especially after analyzing data from that massive Nelson trial I mentioned, we realized two things. One, we were missing some tricky cancers, specifically the ones that look like cysts. And two, we were causing way too much anxiety over things that were harmless. So the mission of V2022 is really about refining that filter, catching the bad stuff earlier, but also ignoring the benign stuff more confidently.
Okay, let's unpack the bad stuff first, because this was the biggest surprise for me in the reading. Segment 1, the shapeshifters.
Yes.
I always thought a tumor was, a solid ball of tissue, but you're telling me cancer can look like a cyst? Like a little air pocket?
It can, and this is a crucial update. In the Nelson trial, they found a startling statistic.
Yeah.
22% of the cancers missed at the initial screening were associated with cystic spaces.
22%?
Yep.
That's nearly a quarter of misdiagnoses. That seems huge.
It is huge. Historically, radiologists were trained to look for solid nodules. If they saw a cyst, an air-filled space, it was often dismissed as emphysema or just, wear and tear on the lungs.
Right.
But it turns out, cancer can grow on the wall of a cyst, or a cyst can actually form because of a cancer's check valve mechanism, trapping air behind a tiny tumor.
So how does V2022 handle this without turning into a panic factory? Yeah. Because I assume we don't want to biopsy every little air bubble in the lung.
No, absolutely not. That would be a disaster. The new rules are very specific about wall thickness.
Okay.
If you see a thin-walled cyst, and we're talking a wall less than 2 millimeters thick, that is considered benign. You ignore it. It doesn't even get a Lung-RADS score.
Okay, simple enough. Thin wall equals safe. But 2 millimeters isn't much. When do we start to worry?
When the wall gets thick, if the wall is 2 millimeters or thicker, or if the cyst is multilocular,
Meaning
it has these little internal dividers or septations inside it, well, that is now a red flag. Lung-RADS v2022 classifies that as a 4A.
And 4A isn't a wait-a-year situation, right?
Definitely not. 4A means it's suspicious. It requires a 3-month follow-up CT or maybe a PET scan if there's a solid component larger than 8 millimeter. We aren't waiting. We need to watch it closely.
The sources mention a danger zone, a 4B classification for these cysts. How does a cyst go from watch it to act now?
It's all about evolution. If that wall gets thicker over time, or if the cyst becomes more bubbled, what we call increased loculation.
Okay.
Or, and this is the big one, if a nodule appears right next to it or inside it. That upgrades it to 4B. And 4B implies immediate diagnostic evaluation. We're talking biopsy or sending the patient to a pulmonologist.
I can imagine that's tricky visually, distinguishing a cyst with a thick wall from, say, a thin cyst that just happens to have a separate nodule lying next to it.
Oh, it's incredibly difficult. It's subjective.
So how does a radiologist make that call in a grayscale image?
Well, V2022 gives a very clear directive for that exact scenario. When in doubt, choose the higher, more suspicious classification.
Better safe than sorry.
We'd rather overcall it and check it than dismiss it and miss that 22% of cancers we talked about.
Right, but let's flip that logic, because better safe than sorry is also what causes overdiagnosis. So let's pivot to segment 2, reducing anxiety. This is about juxtapleural nodules.
Yes. This is the flip side of the update. We want to catch the cysts, but we desperately need to stop freaking out about lymph nodes.
So refresh my memory. In the old version, V1.1, there was this rule about parafissural nodules. Basically, if a nodule was touching the
Track between the lung lobes, yeah.
we knew it was likely a lymph node and ignored it. Why wasn't that enough?
Because anatomy isn't that neat.
Yeah.
We realized lymph nodes don't just live in the fissures. They live along the ribs, the mediastinum, the diaphragm.
Ah.
And the new data showed that specific small, solid nodules found near any pleural surface had a 0% malignancy rate in the studies they reviewed. 0%.
0% is a number you almost never see in medicine.
It is. And it gave the committee the confidence to expand the safe zone. So now, if you see a nodule touching the pleura, whether it's the ribs or the diaphragm, and it meets 3 very strict criteria, you can call it benign.
Walk me through those criteria, because I imagine touching the wall isn't enough on its own.
Correct. First, it has to be solid.
Yeah.
No ground glass. Second, it has to be small, less than 10 millimeters in mean diameter. And third, and this is the most important part, it has to have a specific shape. Smooth, triangular, ovoid, or lentiform, which just means lens-shaped.
So if it looks like a smooth little triangle stuck to the rib wall and it's small...
It's almost certainly an intrapulmonary lymph node. We classify it as Lung-RADS v2022, benign.
So, see you in a year.
See you in a year. No panic, no extra scans, no biopsies. This is going to save a lot of patients from unnecessary stress.
That is huge. It really is about refining the map. But now let's talk about when the map gets messy. Segment 3, the imposters. Infection and inflammation.
Right.
Because real lungs aren't always clean, right? People have colds, they have mild pneumonia.
Right. Real life isn't a textbook.
Yeah.
Sometimes a patient comes in and they have a low-grade infection. The scan looks messy. In fact, statistics show about 8.1% of screenings show inflammatory findings.
And the problem is, inflammation can look scary. It can look like a big mass.
Exactly. But less than 1% of those inflammatory findings turn out to be cancer. So we needed a way to hit the pause button without dismissing it entirely.
And that's where Category 0 comes in.
That's where Category 0 comes in.
Which implies incomplete, right? It sounds like we don't know yet.
That's exactly what it is. If we see segmental or lobar consolidation, basically a big patch of white, or if we see more than 6 new nodules popping up all at once, or a large solid nodule that appeared very quickly, we call it Lung-RADS 0.
And the prescription is wait.
Essentially, yes. We wait 1 to 3 months and scan again. We give the body time to heal.
Wait and see is sometimes the hardest pill to swallow for a patient who just heard, we saw something on your lung.
It is, but clinically it's the best medicine here. If it's pneumonia, it will clear up or shrink in a month. If it's cancer, it won't.
So then what?
If you scan in a month and that big mass is still there, unchanged, then you reclassify it based on what is left. It likely becomes a 4B and you biopsy it. But you gave the antibiotics a chance to work first.
There is one exception mentioned in the notes, something called tree in bud, which sounds remarkably pleasant for a lung condition.
It's a descriptive term. It literally looks like a branch with little buds on the ends.
Yeah.
That pattern almost always indicates infection or mucus in the tiny airways. It's rarely cancer.
So you don't even have to wait.
Usually not. V2022 says you often don't even need the 1 to 3 month wait for that. You can just call it Lung-RADS v2022 benign and keep screening annually.
Fascinating. It really is pattern recognition. Let's move to the tubes themselves. Segment 4, the airway watch. This brings us back to that hidden danger theme.
Yes. Airway nodules are rare. Only about 0.6% of patients have them. But going back to the Nelson trial again, 22% of the missed cancers were central airway lesions.
So they are hiding in plain sight inside the windpipe.
Precisely. And the challenge is distinguishing a tumor from a glob of mucus.
Which sounds gross, but I guess on a CT scan, a blob of mucus and a blob of cancer can look identical.
They can look very similar. So V2022 has a new protocol. If you see a nodule in a segmental or proximal airway, the big tubes, it's a Lung-RADS 4A, you bring them back in 3 months.
To see if the patient coughed it up.
Exactly. If it was mucus, it should move or clear. But, and here's the critical twist, if that nodule is still there, exactly the same at 3 months, what do you do?
My gut says you downgrade it because it didn't grow. Usually, stability is good.
And that would be the trap. In the airways, stability is bad.
Oh.
Benign mucus moves. If it stays put, it's suspicious. So V2022 says if an airway nodule persists at 3 months, you do not downgrade it. You upgrade it to 4B.
Wow. So stability is actually a sign of danger there.
In the airway, yes. It means someone needs to go in with a bronchoscope and look at it directly.
That is a crucial distinction. Let's talk about the mechanics of measuring these things. Segment 5, growth. How do we define growth now? Because it looks bigger, probably doesn't cut it.
No, it doesn't. And previous versions were a little vague. Now, V2022 is precise. Growth is an increase of more than 1.5 millimeters in mean diameter within a 12-month interval.
1.5 millimeters, that's tiny. Why is that specific number? Why not 1 millimeter?
It comes down to the margin of error. CT scanners and, human measurement have a little bit of variance. Anything less than 1.5 millimeter could just be measurement noise. But once you cross 1.5 millimeters, that represents a statistically significant change in tissue volume.
But here's the scenario that scares me. What if it grows 1 millimeter a year? It doesn't meet the 1.5 millimeter rule in a single year, does it? Does it fly under the radar?
That is the concept of the slow grower, and V2022 addresses it head on.
Okay.
If you only compare this year's scan to last year's scan, it looks stable. But if you compare it to the scan from 3 years ago, it's grown 3 millimeters. That is a cancer creeping up on you.
So the advice to radiologists is look back further.
Always compare the current scan to the oldest available CT. That is crucial. If a solid nodule shows that slow creep over multiple years, it's suspicious Lung-RADS 4B.
And what's the move then?
Well, a key point here. Slow growers often don't light up on PT scans.
Yeah.
They aren't metabolically super active.
Okay.
So you might need to go straight to biopsy or surgery. You can't rely on the PTT to save you.
Now, I noticed there was a debate in the sources about volume versus diameter. Computers are great at calculating volume. Why are we still using a ruler to measure diameter? Doesn't that feel a bit analog?
It does. And honestly, the Nelson trial actually used volume. It's more mathematically pure. But in the real world, across different scanners, different hospitals.
Different software.
Exactly. Volume calculations can be finicky. And there was a major study comparing the two methods in clinical practice, and good old-fashioned mean diameter actually outperformed volumetrics in detection.
Really? The ruler beat the computer?
For now, yes.
Yeah.
It's robust, it's reproducible, and it works. So Lung-RADS v2022 is sticking with diameter. Stick with what works until the tech is undeniable.
Fair enough. Okay, segment 6. This is about the soft landing or stepped management. This addresses something called the timing paradox, which sounds like a sci-fi movie title.
It does. But it was a real problem for patients. Here's the scenario. In the old system, let's say you had a suspicious nodule, a 4A. You get scanned in 3 months. It's stable. Great news.
Right. Good news.
The old rule said, okay, it's stable, go back to annual screening. So your next scan is in 12 months.
Okay.
But compare that to someone with a category 3 nodule, probably benign. They get scanned in 6 months. So the person with the more suspicious nodule actually ended up waiting longer for their next checkup than the person with the low-risk nodule.
I see. That makes no sense. The higher-risk patient should be watched closer.
Exactly. So V2022 introduced step management. You don't jump from suspicion straight to annual. You step down.
Walk me through the steps.
You start at 4A, suspicious. If it's stable at 3 months, you downgrade it to category 3.
Which means...
That means you scan again in 6 months.
Okay.
If it's stable again at that 6-month scan, then you downgrade to category 2, and you scan in 12 months.
It's a gradual de-escalation.
Exactly. It keeps a closer eye on those tricky nodules for a bit longer before letting them go back to the annual pool. And importantly, the clock resets from the current exam. You don't try to calculate from the original baseline years ago. It simplifies the scheduling and keeps the patient safer.
That feels much more logical. So we've covered the cysts, the lymph nodes, the infections, the airways, and the rules of the road. Before we sign off, let's hit the outro topics. Incidental findings. The S modifier.
Right. You're looking for lung cancer, but you see a giant aortic aneurysm.
Or severe coronary artery calcification. You can't just ignore that.
No. Lung-RADS allows radiologists to add an S to the score like 4BS. It tells the referring doctor, hey, pay attention to the lung, but also look at this other thing we found.
So it's a flag.
It's a flag. It's subjective, up to the radiologist, but it's a crucial safety net for holistic care.
And lastly, the eligibility question. We have these strict rules for the nodules, but what about the patients? What if a patient turns 81? Or they quit smoking 16 years ago? Technically, they might age out of insurance coverage or eligibility for screening?
This is a common dilemma, but the consensus in V2022 is this. The radiologist should still score the scan.
Even if the patient isn't officially eligible?
Yes. Don't leave the doctor hanging. Give the Lung-RADS score and the management plan based on the anatomy. But add a note saying, Management depends on the patient still being eligible for screening.
Treat the patient, not just the policy.
Exactly. Let the clinician make the call on whether to proceed, but give them the data.
So if you had to sum up Lung-RADS v 2022 in a nutshell.
I'd say it's about closing loopholes and reducing noise. We are closing the loopholes on cystic cancers and airway tumors that we are missing, and we are reducing the noise of false positives from lymph nodes and infections. It's making the map much safer for the patient.
It's incredible how much detail goes into simply looking at a grayscale image.
It really is. And here's a thought to leave you with. Right now, we are still heavily reliant on morphology, on shapes.
Is it triangular? Is the wall thick?
Does it look like a tree and bud? We are using our eyes and rulers. But as AI and volumetrics get better and as we get more data, I wonder if we will eventually abandon diameter and visual types altogether.
For what?
For a purely mathematical risk score, where the computer just says risk 85% based on texture analysis that the human eye can't even see.
That is a wild thought. The radiologist of the future might be more mathematician than visual artist. Or maybe just the interpreter of the algorithm.
We'll have to wait for V2030 for that deep dive.
Indeed. Thank you so much for breaking this down. It's clear that V2022 isn't just a patch, it's a smarter way to screen.
My pleasure.
And thank you for listening. Keep those lungs healthy, stay curious, and we'll catch you on the next deep dive.